Whosoever will be saved, before all things it is necessary that he hold the Catholic faith.
Welcome to Veritas et Thus, or Truth and Incense, a podcast on the one holy Catholic and Apostolic Church, the faith, and the liturgy which is the public expression of that faith, especially as seen through the Anglican heritage. I'm your host, Father Gregory Seeley, rector of St. Thomas of Canterbury in Roanoke, Virginia. And today I have a special guest on to talk about a special subject. This is A.J. Reinhart, who is a clinical therapist and PhD student who deals with mental issues. And I want to talk today about autism. When I was growing up, you never heard the term or what have you, or it was a specific thing. And now it seems like every other person, and I only slightly adjust, is diagnosed with autism. It's a spectrum, and all kinds of different things fall under autism. But I wonder how much of this is real and how much of this is not. So, AJ, you deal with this kind of stuff. What for you are the signs of how would you diagnose autism, and what would you look for in that diagnosis?
Yeah, of course. I appreciate you having me on. And so when it comes to my actual clinical practice, the approach that I take for diagnosing autism is multidisciplinary, right? Meaning that I tend to take a community approach almost, right? I'm going to talk to primary care. I'm going to talk to the teachers. Obviously, I'll talk to parents if it's a child. I'm going to talk to speech pathology, OT, those people, right? Anybody that's been involved in the child's care, it would be something people I would talk to in order to move towards that diagnosis. And the things that I'm looking for from a symptom presentation in talking to those individuals really kind of fall broadly into two categories. One is going to be the social functioning deficits. That's where you're going to see difficulties with interactions, socially, some trouble with empathy, language, gestures, social cues that are maybe nonverbal, things like that, like difficulties navigating that part of life. And then also some restrictive and repetitive types of behaviors, sensory issues, rigid thinking, and routines like inflexibility with problem solving. And then the occasional, I think you'll hear people with autism sometimes talk about special interests. There's a topic or something that they will be like very overly fond of, to the point nearing sometimes obsession. And so those, broadly speaking, those tend to be the two categories that I look for as far as actual like the issues that I'm looking to see symptom-wise in diagnostics.
So, well, that leaves quite a bit of issues that might be diagnosed as autism. It leaves a great deal, anywhere from what used to be titled as kind of the idiot savant who didn't know how to do anything. It's like the movie Rain Man, where he can count cards but doesn't know how. Otherwise, he's almost unable to function in society. To people who are you say missing verbal cues, or don't have a lot of social awareness, um, and so does it how does that how is everybody not autistic in some way, or how is somebody who is, you know who's not paying attention, or I mean, how do does autism lose its usefulness if such a wide scope of symptoms can be called autism? And do we need, I mean, at what point do you leave autism and go into, say, what used to refer to as mental retardation? I don't know what the popular term is today. And on the other side, can you grow out of it? Is this just teenage, high school, whatever, malaise and dreamy, daydreaming, as opposed to an actual medical condition?
Yeah, so I mean, first of all, I would say that I don't like autism being a medical condition in that specific way, right, is a little bit harder to define, right? Because it's not like we do a blood draw and say like, okay, this is here, and so you have autism, or we do a brain scan and say, okay, your amygdala is slightly larger than this other person's, and that is what autism is the slightly enlarged amygdala. It's a kind of a combination. There's subjective aspects to diagnosing autism. And really, that you can almost get into with any mental health disorder is recognizing that there's going to be subjective aspects to it. One of the things that you're describing is like, where do we, how do we navigate the parameters of what is autism versus what would not be, and how do we not all have some semblance of autism, right? And so the diagnostic criteria, even though they have moved from categorical diagnoses, right, your pervasive developmental disorder, autism, and then Asperger's, for example, like those three are categories that used to be diagnosed separately, into the spectrum that we kind of see today in the DSM-5, which is the level 1, level 2, level 3, and then kind of like moving through those things, where you separate them from day-to-day living would be one, the level of distress that's being caused, right? And so, like, for example, how do I tell the difference between sadness and depression, right? Like, if depression is just, well, we get sad sometimes, then how does everybody not have depression? Like, no, there's more defined parameters around it than just we get sad sometimes, right? It's a pervasive pattern of low energy, low mood, and a multitude of like kind of checking boxes, like this symptom, this symptom, this symptom, and it's manifesting itself inappropriately in a couple of different areas of life, right? And so for autism, it's like, it's not just, oh, I sometimes commit social faux pas, and that means I have autism. Like, no, it's more like you are consistently struggling in social settings to the point that you're not able to create friendships. You're ending up in a lot of conflicts really consistently. It's disrupting your ability to be in romantic relationships. And it's the same thing. Like, I'm uncertain of how to approach this conversation over time, right? So I'm not learning or picking up those social cues, and among a myriad of other things. So there's still a checklist element to this. It just, I think it just is a little bit further away from categorical into more, how are the symptoms affecting your actual functioning? And that's a big part of why we shifted from the categorical diagnosis into the spectrum one. Is we're focusing more on, like, how is this functionally impacting you? Like, to what level does this actually cause functional disruption? Social faux pas, for example, doesn't cause functional disruption. It might be awkward in that one moment, but over time it is not creating a chronic problem. Whereas even someone with Asperger's is like, no, like, the majority of my social interactions, I am encountering some sort of awkwardness or difficulty, a lot of anxiety that's debilitating, and other people are noticing, and it's stopping me from engaging in my day-to-day life.
Just so for those who are not familiar with this subject, could you give us a kind of quick definition of Asperger's?
Yeah, sure. So Asperger's, which we've I wouldn't say done away with, but Asperger's has changed. It's not really, we're not using it clinically anymore. But what Asperger's is that it was a way to define primarily the social functioning deficits of autism without some of the learning difficulties or some of the other delays that go along with that. So the comparison would be level 1 autism and Asperger's have a lot of similarities, with the focus being on mostly social difficulties. Previously, someone diagnosed with autism versus Asperger's is the person with autism would have more of the like inflexible routines or restrictive repetitive behaviors, even to the point of like nonverbal, like they can't speak or process language appropriately.
So one of the things I wonder about, and I run into this kind of people all the time, people who are awkward. And I kind of went through some of this as I was growing up. I was very awkward. I lacked confidence. And first of all, I was struggling. Because I was awkward, I developed like nervous tics and various things, up to the point where I was taken to a psychologist, and he diagnosed me with what they call back then borderline schizophrenic, and I was put on medicine for that. And I saw in myself a difficulty in navigating social things. I was very unsure of myself and such. But as I grew older, I began to watch other people, how they interacted. I began, oh, this is how you do it. I would be very nervous going into a situation, see someone else do it and go, wait a minute, I could do that. And with time, I grew out of it. So would you say that I had some form of autism, or would you say that this was just, it was, as I say, my parents were very critical of me and didn't feel like I was, I was very successful growing up, and that may have contributed to that. And again, if I had good parents, but they were, you will succeed. Failure is not an option. And then when I began to fail, that caused even more anxiety. So, I mean, do you think that that's something? Do you think I would have been diagnosed as autistic today with those symptoms?
I mean, it's difficult to say in a retroactive manner like that, whether or not you would have been diagnosed. What I can say from, I suppose this is more anecdotal than empirical, but that I've had, schizophrenia is a diagnosis that I work with some regularity. And so, particularly I've had older clients, older than, actually significantly older than you, like 60, 70 years old, who had a historical diagnosis of schizophrenia, but in reality, meeting with them, talking with them, it became very evident that what they were actually dealing with was autism. And so usually a higher severity form of autism, Asperger's and schizophrenia, for example, I would probably not conflate. It would be more difficult to conflate those two. As you lose functional capacity, as you move up the scale of autism, you can start to run into some similar overlaps with what you might see in somebody with schizophrenia, like disorganized thought, disorganized speech. That can sometimes be a part of that. Schizophrenia, it's going to be more of a structural issue, whereas with autism, might be more of a language comprehension type of issue, and that part in particular. But I think, considering maybe a lack of our current clinical understanding, it's possible that like prodromal syndrome for schizophrenia could be misinterpreted as Asperger's, or Asperger's could be misinterpreted as a prodromal syndrome, which is basically,
what is a prodromal syndrome?
Yeah, so prodromal syndrome basically just means some of the precursor symptom presentation for a larger disease later on. And so schizophrenia, a lot of times we don't see manifestations of the positive symptoms, the hallucinations, delusions, until early 20s. But we'll see something called prodromal syndrome in the mid to late teens, where there's a social isolation, there's some anhedonia, like I don't have an interest in doing things or avolition, they don't have an interest in doing things they previously would have, or anhedonia, my feelings feel very muted. I'm not very expressive, even some blunt or disrupted affect. Their facial features don't match the thing they're expressing. And so there can be some overlap, but the severity in people with schizophrenia tends to be much higher than those with Asperger's.
Interesting. Several years ago, I remember working with some people who I felt were autistic, and one of the characteristic traits I'd always observed, or kind of the hallmarks that I felt were characteristic of autism, was a difficulty in social interaction. That is to say, you can very intelligent, you're in your own head, you can do whatever you have to do, and you can come out of yourself, but it requires an effort. And so oftentimes they would sit next to them and they wouldn't talk to you at all, and you'd think they didn't like you, or they would have situations where it would almost be expected that you interact. They wouldn't. If they had to, again, they could come out of themselves and they could be just as charming or just as intelligent as they needed to be. But it was something you could almost see it took an effort to do. Mm-hmm. And when we talked about this earlier, you disagreed with me to a point and said actually it was this need for rigid rules and structure, and the unwillingness or perhaps even inability to see not just 2 points of a subject, but there's one way out of this and this has to work, kind of thing. So do you I'm not really giving you much of a question here, but is there more than, I guess we could say, is there more than one way of looking at, more than one way of autism manifesting itself, or do you see these things as like, somebody who had no problem with social interaction, but was very, very, very narrow-minded in their way of interacting, as opposed to someone who doesn't interact well, would both have autism?
Yeah, so the kind of that topic is one of the reasons that we saw the switch from categorical diagnoses from that like pervasive developmental disorder and autism and Asperger's, which are definitive category boxes, right? Why we shift your point is a big part of why there was a shift from that to the spectrum, right? Because what was happening is you were running into exactly what you're talking about, which is, well, what happens if somebody has the language deficits that you typically see in autism, but they're not having a lot of the social functioning deficits to the level that you would expect in a person with autism? What box do we put them in? And there was, frankly, I would say misdiagnosis, right? Like someone who is presenting with more autism symptoms is actually closer to the Asperger's scale, or vice versa. And so the spectrum, what that does is it says, okay, we're going to focus on functional impact instead. And so if you meet a baseline criteria of functional disruption, you get into this space, right? And so, that part, that part allows you to kind of be a little bit more nuanced in your diagnosis, right? Which is also, to your point, can be problematic due to now there's just too much. It can be too broad, right? So kind of that balance between recognizing that we need some fluidity in order to be sensitive to where the functional impact is actually happening without putting someone in categorical boxes. And so we're looking more at function versus trait. And so that can make.
Can you hear me? We're having a little bit of a technical issue. Let's see if we can get this. Can you hear me, AJ?
Yeah, I can hear you now.
All right. I'm going to keep going here in our conversation. I still can't see you, but I am.
About
So, what I wanted to mention was there are younger people now who have certain personality traits, which one might say is autistic, and one might say is just immaturity. We talked a little bit about this previously, where the lower, so obviously the more aggressive autism, that's, we can diagnose that, but the lesser autism is many of the traits could easily be seen as either immaturity or just youthful petulance.
Yeah. So I think what some of the diagnostic broadening has done, to your point, right? Has allowed for, I suppose, some inconsistency in what exactly is diagnosable for autism, right? To your point. One of the areas I think that tends to be the most pervasive is in the internet access self-diagnostic sphere, where I kind of get online and I look up or Google what it is that autism is, and then I start to determine that I meet enough of those criteria, and because I meet enough of those criteria, I'm going to self-diagnose or start to behave or act as if I do have this disorder. We see this in medicine too, right? Take stomach issues, for example. If someone says they have a gastro problem, there are a lot of things that could possibly contribute to the symptoms of a gastro problem. And if I start Googling them, I might diagnose myself with all kinds of things that are inaccurate. And a part of the process of utilizing the DSM, but also that the cooperative approach that I described with talking to teachers, talking to parents, talking to primary care and other providers, is to do a little bit of a rule out, right? And so realizing that some of these behaviors can come from other types of difficulties, right? For example, There's an element of rigidity and inflexibility that can come with ADHD. And so is this person, how do I tell between ADHD and autism? If you're just Googling that and someone says, well, I sometimes can hyperfixate and that means I have ADHD. So that's the importance of being able to go to a professional and that somebody can take that multifaceted approach in seeing, and kind of identifying, do I actually believe that this is what's going on, as opposed to, let's say conflict in the home, right? That can cause disruption.
So do you see autism as how much of a disability do you see autism as in substantial? I mean, it is something that um, is most autism functioning autism, or is autism something that is and I realize in saying this there's the spectrum, but um, I, I think that I think that I think that the um, combination of people leaning into this idea of, oh, I can't change, I'm autistic, or this is a problem, it's just autism,
Mm-hmm.
to being in denial of autism. I wonder how much of a disability do you see autism really as being?
I think is very much dependent upon, like where in that spectrum you fall, right? Because when and kind of that question is kind of the point of the spectrum is recognizing, like, okay, where is the functional difficulty occurring? And so if I am predominantly struggling with like some rigid problem solving, the social cue issues, and you know you meet with your provider and you got and they determine that this is related to autism, um, the level of disability is going to be, well, how do I function socially, right? And so like the disability ends up being in my social functioning, versus more severe things where you're having learning disabilities and developmental delays that can accompany this, where there are people that are level 3 autism that will never be able to live on their own, right? And so the degree of disability to functional status is very much the part of the spectrum, right? Like that's what the diagnostic spectrum is now, is like, to what degree is this impacting your functioning? At the very, very low level, maybe you need some interventions geared towards socialization, communication, flexible problem solving. At the very, very high end, it could be this person will likely need supervision, for the remainder of their life. And some sort of caregiver or guardianship type of role. And so it does run that broad spectrum.
And what percentage of autism would you say you could, if the person were made known or to be coached and taught in an area, do you think that most autistic people, can they be told, hey, you should really be doing this, or you're doing something that's unusual, unreasonable, or are they usually able to recognize when they are behaving on the spectrum, and come to realize that their behavior is unusual or unreasonable or problematic?
Mm. I would almost want to take that almost person to person, right? Because there's this. I think in my conversations with people that have autism, what they will tell me with some frequency is that they already feel other, right? They feel somewhat alienated, or they feel, like they're just not matching whatever social cue, or not matching whatever social norm they're encountering. An example of that I've encountered is, I had a client of mine, very sweet man, who had asked me why we shake hands. And he refused to shake people's hands. He just would not do it. And he would get a little upset if you pushed the envelope. And so when I talked to him, like, hey, do you understand, like, this is we talked a little about the history of like why you shake a person's hand and when you do that and what that means. And once he understood the logical reason for it, he was like, okay. But prior to understanding that, the manifestation of it as just a social norm, he had a hard time just accepting that, right, without any type of, why am I doing this? And he got a little rigid about it. And so I do think that that's probably a bit individual as far as level of insight. Um, obviously somebody, or maybe not obviously, but somebody on the level 3, like towards level 3 or more severe forms of autism, is going to look something closer to full intellectual disability, right? Where some of them, even to the point of being nonverbal, right? So level of insight there is a little bit more difficult to gauge. But for someone that's lower on that spectrum, that's running into more social cue issues, I would say, yeah, they perfectly have the capacity to recognize, like, this is very, very awkward for me, and I feel very uncomfortable. I'm not exactly sure why, but I do feel very uncomfortable. And whether or not they assign that to other people versus recognize that it's a discomfort that's internal. I don't have statistics on that, but anecdotally, what I will say is most people communicate to me that they feel other. That their recognition of that is that I feel like I'm weird, or I feel like I'm out of the social norm. Not everybody else needs to do something different for me.
Interesting. So there is some realization that everybody else does this, and I don't feel comfortable with it, or I feel, is there do they have that sense of like everybody else is doing this and I don't want to?
Again, that's hard to say. That might be more like asking that person individually, but there's a lot. I think that's a multifaceted thing, right? And one, trying to figure out what are the rules, right? It's kind of that rigid problem solving. Like, what are the rules of social engagement? And I'm having a hard time figuring what those are. Like figuring out what those are, right? So when we look at certain types of like certain types of interactions that are default mode network, right? Like our social functioning, like switching between internal and external locus, like focus and locus of control. That's something that people without autism will do very naturally. Whereas when someone with autism encounters some of those types of things, it's a little bit harder for them to determine what's going on. And I can give an example. I can give an example of this to be a little bit more, maybe that'd be helpful. So if we take into account something like, should I hug a person? Right? Like that question, should I hug a person? And if I asked you that, obviously, like, should I hug somebody? Your answer to that is going to be something probably like, well, that depends. Like, you can't just give me a carte blanche. Yes, you hug people, or no, you don't. And so for a person maybe with high functioning autism, they might ask a question like, well, when do I hug a person versus when do I not? Like, what's the rule, right? And your answer is going to be like, well, it's hard to tell what the rule is. Sometimes, depending on the situation, the person, and your relationship, and the environment, and all these factors that you have to. And when you get into it, you almost think for yourself, like, wow, there's a lot that goes into me making the decision in a moment about whether or not I can hug a person. And so some of that processing doesn't happen quite as naturally for people with autism.
I was going to say, sometimes I'm not sure. So
yeah, exactly. Yeah, exactly.
I know one of the young men that I work with who may or may not is rumored to have autism. When it comes to shaking hands, will put his hand out but won't grasp. It's they call it's the dead fish shake. And I've even mentioned, come on, squeeze my hand, and then he will, and then he won't.
Yeah. Yeah. And so again, like, sorry, go ahead.
I just say I don't. Somewhere I think that even if he knows it, I think he's uncomfortable with it. So he shakes hands, but there's almost a sense of like he's not even sure he really wants to be touched. Quite honestly, if he's supposed to do it, so he does it. But there's no because there's no desire, or there's a level of uncomfort with it, then he's not going to do it. Even if you tell him he's supposed to just squeeze your hand, at some point he's not going to anymore, because I would almost suspect deep down he doesn't really want to.
I mean, that's possible. One of the, I think one of the things that tends to go along with the diagnosis of autism, even high functioning, tends to be the sensory issues that are associated with it, right? Like shaking someone's hand, like physical touch, right, might be very uncomfortable. And it's there that we start to get into the conversations about some of the neurology of those disorders. When we look at like frontotemporal regions of the brain, your prefrontal cortex and your temporal lobes, the idea of overstimulation and having a limited ability to prioritize input, right? So and so you can end up with like overreactivity and underreactivity, or hyper skin sensitivity, whereas I can drown out this other thing. And there's not a lot of that system seems to be disrupted in people with autism, right? Where you hear like loud sounds, which would be more your temporal cortex, but like you hear these loud sounds, and I can't focus or concentrate if there's a loud sound. My brain won't filter that very well. Or auditory processing, like I'm not doing that well with language. The overstimulation piece on physical touch, right, is another area of that where your brain is telling you like, okay, I feel oversensitive physically by being touched like that. It elicits an actual physical reaction out of me that they don't necessarily have control over.
So, what, in some senses, wouldn't it be easier to take this thing and break it into, I'm trying to think of a good word for it, like dilemmas or something or other of like, I'm so and so's like antisocial, or so and so has this or that issue, and have whitish categories rather than talking about a spectrum. Because when I get to a spectrum, it seems to me that it's both easier to diagnose and easier to overdiagnose someone into autism. So what benefit do you see in having the spectrum versus having a collection of, say, 7 or 8 things like Asperger's? Okay, you have verbal this, or you have social that, or physical this, and you could say, oh, so and so has this syndrome, shall we say.
Mm-hmm.
And being able to pinpoint the behaviors rather than putting it into this thing called autism, which can manifest itself in various ways.
Sure. Yeah. So I think you could probably still do that effectively with the idea of a spectrum, right? Because even if we talk about a spectrum, it still has parameters on the high and the low end, right? You still have those. And so if you take, for example, level 1 autism, there is a line from which you can be subclinical in your presentations, right? So there is still a definitive like diagnostic categorical box, if you want to say that, right? That is level 1 autism. You can have symptoms that are too low to meet that criteria. You can still not meet criteria for a diagnosis of Asperger's, right? It's not just like, oh, if I'm socially awkward, I now fit into a category of Asperger's, right? So when you look at the DSM-5, and we can debate validity of the DSM-5, but when you look at the DSM-5, there are still categorical pieces to it, right? It's like, okay, this person has to express this many difficulties in social functioning and this many difficulties in restrictive and repetitive behaviors in order to meet baseline criteria for a diagnosis of autism. Now, once we hit that threshold, from there all the way up to level 3, which is that high severity presentation, that part is the spectrum, right? And so it's not like every social interaction is a spectrum of autism. There is a baseline threshold that you need to meet, and then once that threshold is met, from there it becomes a spectrum.
And what kind of once you have a diagnosis of autism, how do you treat?
Yeah. So treatment for autism is, again, I think that it tends to be multifaceted approach, like it is with most mental health disorders, right? You have combinations of pharmacological interventions and then also therapeutic behavioral interventions. And so the gold standard for, to our current knowledge for autism in children in particular is ABA, which is applied behavioral analysis, right? And so this is a very like adaptive behaviors intervention style that goes through communication, social skills, and it uses a lot of reinforcement, right? You do something well, something good happens. It mimics positive reinforcement, so you can build behaviors. You can also have some cognitive behavioral therapy that can go along with that, related to if there's some rigid thinking or anxieties that can kind of manifest themselves as a part of that you can work through with that person, help them use skills to process rational versus irrational fears and beliefs. And then you have that teams approach, right, where you have speech and language therapy to help people catch up with those language deficits. You have occupational therapy to help them catch up with self-care and independence. And then pharmacologically, we tend to look at, I'd say, a couple of medications that we use were like risperidone for some irritability or mood changes, and then some SSRIs, right, antidepressants, things like that can help people kind of navigate really the reactivity to some of the rigid problem solving, right? So it can help them address some of that reactivity that they experience, which can be very uncomfortable.
So in some way, you say somebody who has, say, a learning disability in regarding language, or a learning disability in regarding math, or a learning disability in, you'd use some of the same tools. You're just saying that in this case, it isn't just a learning disability regarding language.
Mm-hmm.
There are more factors to it, and
yes.
So the same tools might be used, but you might not necessarily expect the same result.
Yeah. So the learning disability part is, I would say part of a whole, right? And so like if you have somebody that's presenting with like, hey, they are failing in math and they're doing well in English, but their math is just really, really bad. But they don't have any of the social functioning deficits. They don't have any of the repetitive or restrictive behaviors. It's just kind of in a vacuum, like I'm just struggling with math, right? So you would have maybe something like dyscalculia, right, where you're switching numbers around, or things like that, right? So you want to look at, again, functional impairment, which is kind of the goal of all the diagnostic changes towards that spectrum, is where is the functional impairment? And if it's specifically in a learning area, then we're going to categorize that as a learning disability, not autism, right? Because it's specified in that area of learning disability. Now, people with autism can have learning disabilities, but people with learning disabilities don't always have all of the social functioning deficits and the restrictive repetitive behaviors that you'll see in somebody with autism. And so, yeah, the treatment of those things can be very similar.
That makes sense. Trying to think what else I wanted to ask here. I mean, in your opinion, professional opinion, although you do more schizophrenia, autism, do you think autism is overdiagnosed nowadays?
I don't know if I can speak to that. It's hard to speak to that personally, right? Because I have like an anecdotal experience. When I look at data, the data shows that there is a pretty significant increase in the diagnosis of autism in the last 20 years, right? Kind of going from like, one person in like 150, or so in the year 2000 to like 1 in 40 in the last 5 years, right? And so, yeah, that I think that is difficult. Like, why did it go from 1 in 150 to 1 in 40, roughly? Is that related to increased awareness of those symptoms that would previously have gone unrecognized, right? Like people with high functioning autism can mask very well, and in some cases, they experience a lot of distress and anxiety and social disruption, but they kind of just ignore it, or people learn to just deal with it, all the way to, because we've expanded the parameters of this diagnosis, are people more likely to, like, are people looking for it, right? So like a little bit of red car fallacy, right? We're being told to look for these things, and now that we're being told to look for these things, we see them everywhere. That's really, really hard to say which of those things is occurring. I think experts, more intelligent than me, the CDC and some of those places, will describe that that's related to just higher levels of awareness that has caused people to step forward and say, hey, this has been really, really disruptive. It's been really hard in my life. And I'm finally wanting to talk about it because it's been normalized that we can talk about it. And that I do see anecdotally in my practice, more so with ADHD than with autism. I have a lot of adults that come forward and say like, hey, I've actually really struggled with motivation and energy and working memory and my thought process. I've always struggled with this, and it's really, I almost failed out of school because of it. I really struggle at work because of it, and I always just thought I was lazy. But now I'm hearing these things, and so I'm in your office to determine, like, am I actually lazy, or is this actually a neurodevelopmental disorder? And so I can anecdotally say that I've seen an increase in people that are adults coming into my office wanting to know, like, hey, is this what's going on? Because when I was a kid, people would just kind of shrug their shoulders at this, but now, these really resonate. These symptoms really resonate, and they've caused me a lot of disruption in my life that I've either just ignored or I've kind of just browbeat my way through.
Interesting.
Yeah.
And is how treatable is that to somebody? And I have another line of questioning after this, but how treatable? I mean, if someone shows up to you,
Yeah.
later in life or what have you, I mean, or even do you get referrals like, boy, my mother or my sister or whatever else has always been like this. I wonder if they have it, as opposed to even like someone who feels that they have it. Is this something, do you see that? Is it something treatable?
Yeah, yeah, absolutely. It's something treatable. Um, a lot of that comes down to behavioral intervention, right? And so working on recognizing that just because I feel like acting a certain way doesn't always mean that I need to act that way. And
Uh-huh.
you and I, and neurotypical people do that all the time, right? Where it's like I feel like I want to be angry with this person, but I can pay attention to my situation, my environment, and determine that I'm going to behave differently than how I feel in this impulsive moment, for example. And people with autism are capable of the same thing. It may be a bit more difficult for them to do that, but yeah, it is treatable with behavioral intervention and modification, things like that. Yeah.
All right. Do you think, and this is one of kind of I won't say a conspiracy theory that floats around, but it's a hypothesis that do you think that things like vaccines or habitually bad diets or things like that can cause some of these problems?
So I think when you look at the neurology of ADHD of ASD of autism, ASD is short of autism spectrum disorder. When you look at that, when you see things like increased like cortical thickness, higher neural densities, enlarged amygdala, structural differences in like their limbic system, the connectivity issues in default mode networks. Like when you look at those neural pathways and the problem or those structures and the difficulties you see in those, it's easy to ask yourself the question like, okay, is it something I'm eating? Is it something that's is it something that is it a medicine that can affect these things and these structures? How genetic is this? What are the things that play into what's causing these structural abnormalities in this person's brain or limbic system? What's causing it? And that's a thing that we don't quite have an answer for. And so I think there's a lot of speculation on what could contribute to that. But as we learn more about our brains and development in particular, we really move into this space of like nature and nurture kind of coexisting and co-occurring and working on one another simultaneously. And then plasticity, right? Like our brains adjust to our environment, and our environment impacts our brains, right? And so like that, there's a lot of back and forth and interplay and co-occurring change that happens in our neural structures. And so and we believe with our genetics. And so I'm not trying to dance around your question. It just I think the reality is that when you see these structural differences in people with ASD versus neurotypical people, you do ask the question like, well, what's causing the structural differences? And the theories that are out there that there's metabolic reasons for that. There's genetic reasons for that. There's environmental reasons for that. And the reality is, if I had to lob a guess, it's going to be, well, it's a combination of all of them.
I don't know. Again, I obviously you hear through the various forms of media, news and otherwise, accusations being leveled and with more or less evidence and
Hmm.
anything from scare tactics to genuine concern. And I mean, I always go back to there's a comment made the other day by Robert F. Kennedy, who's I think it's he's the health secretary, it's Health and Human Services Secretary, and he
Hmm.
said he was growing up with the Kennedys, and there were 20 or 30 kids in the family, and no one was sick, like nobody. And now he goes to an airport, and like every fifth or sixth person has got some sort of problem, and they're sick. He's like, there's something wrong here. So it makes
Yeah.
you ask someone who's involved in the field, you know, have the number of cases of, you know, more severe autism
Yeah.
really increased in the last years enough to say something's wrong here.
Yeah. Yeah. I think that that's fair. Um, the you know what I think is inadvisable is trying to approach something like autism with the same goal as you would maybe approach something like strep throat, which is okay. Can we find the bacteria that causes this thing, like a 1-to-1? And what we've seen over and over again in any type of development, right? Like whether you want to talk about typical development or any of the types of atypical development, is this is a very multifactorial issue, right? Like my belief is that it is very unlikely to be one thing. I think it would be very unlikely that in 10 years we go, oh, it was our food causing autism, as opposed to there is something in our food that contributed to some of the structural things that we see in the brains of people with autism. It contributed to that diagnosis, and kind of trying to see like, okay, well, what are the things contributing to that diagnosis is going to be, my belief is it's going to be way more than one. It'll be a
Right.
combination of
It's almost
lots of things.
like a comorbidity factor in the sense of somebody, this wouldn't have caused a problem, but since there was already a weakness here, there was already a problem. This just impacted it more severely or compounded the effect.
Sure, yeah, exacerbated it. Yeah.
All right, wonderful. Well, thank you, Roger. Do you have any final thoughts on the subject before we say farewell here?
Yeah, I think, and I appreciate the time, and did my best to answer the questions as accurately as possible. Definitely not a human encyclopedia, so if I was incorrect in any area, I'm happy to acknowledge that. But the the I think that the main thing here is the movement from, in a diagnostic standpoint, from traits to function, because at the end of the day, when it comes to treatment on my part, and I tell my patients this is, my goal is to help you get some relief, right? Like you're telling me that you're experiencing distress in some of these areas, and my goal is to help you find relief. And sometimes like the label can give you an avenue, but the reality is focusing on the symptom presentation and how it's affecting your functional life,
That makes
and
sense.
working in that area, right? And so no matter what we want to call it, you're in my office because you're experiencing distress, and I want to try to support you in developing skills that can help you find relief in those areas of distress. And I think a lot of providers would align with me on that, is that functional symptom approach of less worried about what do we want to call it, and more worried about where do you experience trouble and how can I help you find relief in those areas.
That makes sense. Um, that's interesting. I appreciate that. Um, awesome. Well, thank you very much for your time.
Yeah,
Uh,
of course.
I think this was very interesting and very good.
Yeah, appreciate it, Fuzzy. And sorry about the camera.